Hi, everyone. My name is Jonathan Colemere. I'm the Interim Executive Director for the Alamo Breast Cancer Foundation. Thanks for joining us today. We're going to have an advocate chat discussion on the subject of ductal carcinoma in situ, also known as DCIS, with Dr. Laura Esserman from the UCSF Breast Care Center. Dr. Esserman is a surgeon and breast cancer oncology specialist. She's the director of the Breast Care Center at UCSF. She also leads the I-SPY trials, the Athena Breast Health Network, and the Wisdom Study. Esserman is an inductee in the Giants of Cancer Care 2018 for cancer diagnostics and the Less is More approach. Dr. Esserman was also recognized as a Time Magazine Top 100 Most Influential People in the World in 2016. It's an honor to have you with us today, Dr. Esserman. Thanks for joining us.
Thank you for having me, Jonathan.
Absolutely. So I just kind of want to start off with the basics today. Tell us, what is DCIS? How would you describe it in terms of on the spectrum of breast cancers?
So I don't consider DCIS to be a cancer. Ductal carcinoma in situ is the accumulation of cells within the milk duct. So if you think about the breast is made up of, it's a gland, and it has, it's really a gland, it's a milk making factory. Really, so it's got the factory that makes milk, these are the lobules, and it's got roads that lead to the nipple. And those roads are the ducts. And the cells that line those ducts are called ductal cells. It's really not that complicated. Now, normally there's just a nice single lining or one or two cells that line those ducts. But when a cancer occurs and it allows uncontrolled growth of these cells, they can pile up in the duct. And as long as they're confined to the duct, they themselves are not life-threatening. In almost every case, they are not life-threatening. But it is that they have the potential to go ahead and cross the basement membrane and invade the tissue or the lobules or the fat and dense tissue around them. Once they've done that, that is called an invasive breast cancer. And as you know, the amount of risk this poses depends on the biology of the cells, and how and where those cells are and how far they have spread. Now, it turns out just like there's many different kinds of invasive cancer, there are many different kinds of ductal carcinoma in situ. And the type that you develop often is a predictor of the type of invasive cancer that you might develop. But by no means is DCIS an obligate precursor. It doesn't mean once you've got it, then for sure you're going to get invasive cancer. It just means that you are at risk. That's sort of where we are and what we know.
How often would you say, do we know how often it transforms into an invasive form of breast cancer? How often does that seem to happen?
So I think that this is the big question. If you look at the natural history studies, there's anything from like 10 to 50% chance that it would become invasive cancer. It's really not very clear. However, the one thing that we do know is it cannot be that most of these go on to develop breast cancer, because DCIS really is a diagnosis largely because of screening. The incidence rates went up about 500% once we started screening. So we're looking more. These are found by, the calcium deposits. They make a particular set of features on a mammogram, these little white dots, and that's cells dying, or kind of the footprint of these cells along a duct. And that alerts the radiologist to the fact that they're there. Now, despite the fact that for at least 20 years, we've been taking out now 50, 60,000 of these cases a year, we have not seen a drop in the invasive cancer rates. If all of these were the precursors of invasive cancers, the obligate precursor of the invasive cancers, then the invasive cancer rates would have come down. That happened with cervical cancer, when we started taking out some of these small lesions, but it did not happen with DCIS. So for sure, we are overdiagnosing many of these. The question is who? And how do you figure out who's really at risk to go on and who's not? And what's the best treatment and what's the best approach? I think that is actually something we don't know very well.
On that subject, do we have any established or known biomarkers or any other signs that a DCIS might transform into a more invasive form of breast cancer? Do we have any guides for that or hints at what may lead to that worse outcome?
Well, there have been many studies to sort of look at that. There are certain features of DCIS that make them riskier if they present as a mass, just like, something that's like a 3 centimeter mass or something you can feel. That is a worse risk factor. I think people, in general, are more concerned about hormone receptor negative breast cancer or DCIS as having a higher chance of going on to be an invasive cancer, and in part because that's the kind of invasive cancer it's likely to develop. But grade is actually not that great a predictor because, over half of DCIS are considered to be high grade. So taken together, there are features that make these more risky, but there isn't anything that we would basically say, aha, for sure you're in trouble. I think in general, if you have hormone receptor negative breast cancer, if you have hormone receptor negative DCIS, that is something that we think is, for now, something that should be removed. But I think a really important question that we need to ask is DCIS really a focal lesion? Meaning, is it really something that identifies a particular area of the breast that is at risk? So is it really amenable to surgery, or is it a risk factor? Recall that lobular carcinoma in situ is considered to be a risk factor. And pretty much because Dr. Hagenson in the late 40s, early 50s, declared LCIS to be a risk factor and DCIS to be something we should be operating on. And in fact, there isn't really that much evidence. We do know that DCIS also is a risk factor for bilateral breast cancer. So I think an important question for us to ask is, does it make sense for us to really take our time and understand who's at risk for a more global or a potential problem across both breasts, and who really has a focal area that's been changed or that's abnormal, where we know surgery is going to actually do the job?
Right. Yeah, that definitely leads into my follow-up question on that, which was going to be, are we overdiagnosing and overtreating, DCIS? Are we putting too much focus on this, form of cancer that I know, as you said yourself, it's many, doctors refer to this as stage 0 breast cancer or a pre-cancer. It's not necessarily, it receives potentially more focus, than the invasive cancers. And so for the layperson, someone who has no direct connection to breast cancer, knows nothing about it, and just goes, to their doctor, and their doctor says, you have breast cancer. And so there's an assumption there, there's all this baggage associated with, the words breast cancer. And so are we not doing a good enough job to make a distinction between the outcomes for DCIS and the outcomes for more invasive forms of breast cancer?
Well, I think that people are very frightened when they hear the word cancer. And I think most physicians tell people that they have to make a decision in the next few weeks and that they should, get their surgery done. And I think that creates a lot of anxiety and fear. When in fact, DCIS is not an emergency and there's time to actually ask questions. And I think that women are particularly frustrated because I think they feel like, wow, I've been told I have stage 0 breast cancer, but I'm being offered the exact same options as if I had invasive breast cancer. And a lot of people do their own research and they'll come in, and a lot of people will come to me and say, well, they have read everything and they're like, I don't understand why I've been told that I have to have surgery tomorrow. And it's actually a really good question. And one of the things that we've learned over the last year is that, learning a little bit more about the DCIS and learning how it behaves, particularly under conditions of where you're trying a risk-reducing medication, can really tell you a lot of information. And it can give you very different options. And it might actually be the key to helping us understand who's at risk for kind of bilateral breast cancer and where is a risk-reducing medicine that really shuts some of that behavior down in the neighborhoods where these cancers could arise, and who's really better served by having a focal removal of an abnormal area in the breast. And, I think part of the problem we've had with DCIS is we've basically been doing the same thing for 25 years. And, it's hard to find a different option and find different outcomes if all you do is remove them all the time.
Right, right. What would your reaction be to, case reports or anecdotal reports of, doctors recommending radical treatment options like double mastectomies with reconstruction following a single recurrence of DCIS? I mean, it does seem to me to be a very, very aggressive approach that some, doctors and surgeons take to treat to talking to their patients about DCIS, and the idea that a double mastectomy would even be presented to a patient who may have only had a presentation in a single breast. Could you touch on that?
Well, I think, I always like to say it really depends on someone's situation. If you're a BRCA2 carrier, for example, and you've been doing high risk screening and you get a diagnosis of DCIS, you might say, you know what, that's my first sign. I don't want to sit around and wait for the other shoe to drop. Okay, you might be in that 1% of people who really does have that very high risk, and that might be really very appropriate. On the other hand, you can see how easy it is to do this. Maybe there's calcifications in more than one area, and someone says it's hard to really do this cosmetically, and someone's saying, well, gosh, if I have to have this breast taken off, I think I might as well have the other one, and then I'll look even. And one thing leads to another, and the next thing you know, you're doing this pretty big operation, or someone who is young, has young kids, is really frightened. They're like, oh my gosh, I don't want breast cancer. I don't want to have to deal with this. Maybe the best thing for me to do is do both. Or I have my mother had breast cancer. Maybe this is a sign, even though I'm not a mutation carrier. So you can see how it can be very frightening. Or, someone can say, well, the first reaction can be, oh, I'll just have both breasts removed, or I'll just have the whole breast removed. But if you give someone a week or two to think about it and make sure that they know it's not an emergency, very often they change their minds. And I've taken a very different approach to how to think about this. I started probably close to 20 years ago, a registry, and people from all over the country, world actually, would find me trying, they had read up on things and they really did not want to have surgery. Or maybe 6 months had already gone by. They had already voted with their feet. It was pretty clear they weren't going to have surgery. And I said, okay, well, it's not a completely unreasonable thing to do, and I'll follow you. But what I'd like to do is I started a protocol where I was watching people as we developed MRIs. Dr. Noah Hilton and I have, built a lot of these studies, imaging studies, and use that as a catalyst to try and change the way we treat invasive breast cancer, starting with, systemic treatments first, either neoadjuvant chemotherapy or immunotherapy or hormonal therapy. It's so important, once you're starting with systemic therapy, you're really getting an answer about how the breast tissue behaves. And that information is perhaps more important than the information that you get first. We're so used to thinking, oh, there's a breast cancer, cut it out. Let's just operate first. But that's not necessarily the smartest thing to do. What you really want to know is, if you're going to take hormone therapy to reduce your risk, or you're going to have chemotherapy because you've got a cancer that's aggressive, you might as well do that first and see what happens to the tumor that's in place. That is the most important information you can get. If someone came in with a 4-centimeter hormone positive breast cancer, we would start with them with hormone therapy. They're going to take that for 5 years, and we would sequence the surgery 6 months later. So why in the world would we not do that for DCIS? And over the years, I began to realize that there are a lot of people who just have a little bit here, a little bit there, and a little bit there. You can't really get it out. And so it's not really that it's that aggressive, but there's no surgical way to get it out. That's what leads people to a mastectomy. But in fact, if it doesn't really form a mass in the breast, or it doesn't look that aggressive, and you give someone endocrine risk reducing therapy like tamoxifen or an aromatase inhibitor, that the background enhancement, or the risk, which is also a risk factor, the background enhancement that you see on an MRI often will go away. And what we've now discovered is that's a really good predictor of who's going to do well. If the background enhancement goes away and the mask kind of goes away, you kind of know that that person is going to do well with risk reduction. One of the clues that we had for this was back in 2003, when the Women's Health Initiative data got published. That showed that combined hormone replacement therapy increased the risk of breast cancer. And Premarin, which was made by Wyeth, was the largest selling pharmaceutical in the country at that time. When those results came back, the sales plummeted. And that's the only time in the incidence of breast cancer has dropped.
Okay.
In the next 2 years, there was a big drop in the incidence of breast cancers, meaning that the hormonal treatment or environment that people took just changed the nature of when people would develop breast cancer. It was a clue to say that, if you can get the environmental conditions right, you can stop breast cancers that are already growing, you can suppress them, and you can actually, that's what prevention is really all about. And so what we've really found is that you can characterize someone at the beginning with an MRI, and you can see, is this a focal mass? Or is it really just kind of everything kind of lights up everywhere? And for the people who don't have a focal mass, very often that background will just get better. And we know those are the people who are going to be, the most likely to do well. If you have a focal mass and it gets even more apparent with endocrine therapy or endocrine risk reducing therapy, then that person has a focal lesion. Probably that's what needs to be operated on. But that's not the majority of people. In fact, in our study, it's probably maybe only 30%, this is looking at women with hormone positive DCIS, which is about 90% of all DCIS. And so we're going to actually run a big multi-center study to see if we can replicate this. But I think this is really, well over half of women may not need to have surgery. Maybe the best thing to do is to take this as an opportunity to think, oh, can I reduce the bilateral risk that's posed by this? I mean, it's interesting that someone who is a BRCA carrier actually has more risk than someone with DCIS. But we don't force them to all have surgery. Now, many people wind up getting bilateral mastectomy as prophylaxis, but many don't. And we don't say, oh, you can't do that. So it's just a different approach. And importantly, there are new medicines coming up and there are new ways to think about it. By starting differently, this is what we did in I-SPY, right? This is how we found, like for triple negative breast cancer, we now have a combination of Taxol and an immunotherapy with a PD-1 inhibitor that doubles or triples the chance the tumor will go away with chemotherapy before surgery, which means that someone's going to do really well. So why aren't we taking this approach earlier and start thinking, well, wait a minute, maybe this is a window to think about prevention. If we see someone who's got risk, but their life isn't threatened right this minute, this is our opportunity to try and figure out how to make it go away. I think this is a path that's going to get us a lot farther faster, because that's the name of the game.
Absolutely. Yeah, no, that sounds like that's an excellent question to be asked. I mean, challenging the current ways of thinking here, it just really does seem like, so many, especially women that have no previous connection to breast cancer, they don't necessarily know the difference between an invasive and a non-invasive, and the words breast cancer are so scary. So to reevaluate the way that we approach this, this process seems like it would benefit everyone, patients, practitioners across the board. Fascinating research that you're going to be doing on that. That's a really good question. It kind of leads me to my a question I had about the efficacy of these endocrine therapies in terms of patients that can go on an endocrine therapy like sorry, I'm drawing a total blank right now, a tamoxifen. How many of these patients, if you had to guess, would not necessarily need surgery, in the 3 to 5 year period afterwards? I mean,
I think well over half. And I think what's really interesting is that I think tamoxifen, and we have some other clues from this from other studies, I think tamoxifen is particularly good at preventing disease that's more luminal A breast cancer, where you have this kind of slower growing with this long tail of recurrence.
Mhm.
And that maybe we need, the aromatase inhibitors, or maybe the SERMs or the SERDs or the next generation drugs might be better at preventing luminal B disease. But this is the way to find out. You got to start first, and you
Right.
got to do it while you've still got the biomarker intact.
Right.
And it's safe. If you can do it with invasive cancer, for sure you can do it with in situ cancer.
Right.
The other thing is, Dcis, the Italian surgeon, actually ran a trial of looking at 5 milligrams of tamoxifen, which actually turns out to be much better tolerated. And in DCIS, he got very similar results to what you'd see with 20 milligrams of tamoxifen. And then Per Hall, a physician from Stockholm, ran the study using breast density as a short-term indicator of looking to optimize dose. And he tested many doses. This is, I think, published in JCO, and they had 0, 1, 2.5, 5, 10, and 20 milligrams of tamoxifen. And it turned out the lower doses, 2.5, 5 milligrams, worked just as well to reduce density. So it suggests that a lower dose is just as effective. We started with 40, then we went down to 20, but no one really pushed the envelope to see if lower doses of tamoxifen would work. A lot of times we put the drugs on the market that are the maximum tolerated dose, but we don't actually look to ask what's the minimum effective biologic dose. And that can really reduce your side effects. And I'm truly impressed. I used to think from the breast cancer prevention study that, other than hot flashes, most people didn't really have a lot of side effects. But these recent studies really show that the tolerability of the lower doses is much better. And I have found that most people have no problem tolerating 5 milligrams of tamoxifen. Now, is that the right thing? Should someone who's, postmenopausal be given only an aromatase inhibitor so they don't have the endometrial lining buildup? These are all questions that we don't know, but there are new classes of drugs coming out on the market. The selective estrogen receptor degraders, that they're not on the market yet, but they will be in the next few years, and they may be even better and better tolerated. So I think it's, if we really are committed to saying that we want to reduce the risk of breast cancer, and we really want to do something about it differently and to do it now, I think we can use DCIS as a window, as an opportunity to really understand more about biology and start figuring out how to reduce the risk of the various cancers. I think it's a great opportunity. And I, for one, want to see a big, big push in this direction, because it's been 30 years for me. Our treatments aren't perfect, and I'm tired of watching people die, and suffer. We've just got to do better.
Back to the subject of just the screening process, the screening guidelines, I know that in your wisdom study presentation, you had talked about all the variations of screening guidelines across the breast cancer ecosystem. Some recommended beginning mammograms at 40, 45. Could you comment on the concern that many women have with this notion of a mammogram exposes a woman to, it's a low dose of radiation, but it is still, exposure to radiation. Do we know whether there are any long-term consequences, to continuing to make this the standard screening practice to expose a woman and her breasts to, radiation screening technologies? And a follow-up to that question would be, are there any other screening technologies available that could reduce the exposure of radiation, or potentially eliminate radiation exposure to women from a screening perspective?
So those are good questions. And I'm happy to say that I think there's been a lot of advances. The amount of radiation that a woman will receive now is about 10-fold lower than it used to be. So that there's been a lot of advance there. We know that the breast tissue is sensitive, and up until the age of about 35, there really is, potential risk. But over the age of 35, that risk gets to be almost negligible. The amount of radiation you get in a mammogram is the about the same amount of radiation you get in flying on a plane from San Francisco to Denver. So it's not that much. That's not a great reason to say, oh, the mammograms are bad. Now, people can say they're uncomfortable. I don't like them. I'd like something better. Okay, those are good reasons to think about trying to do something better. We don't have a better tool yet. We don't. But I'm hopeful that something like diffusion weighted imaging, a non-contrast form of MR, that could be something that could be very effective and something that we could use that wouldn't require that. Another, I think for people who are really at high risk, clearly would have a high risk, and this is one of the reasons why I really feel it's important to do risk assessment and figure out who needs what, is that the contrast, some kind of contrast imaging is definitely better than mammography, and it's better than 3D mammography. I think there was a hope that tomography, 3D imaging would be better, but it's not. So if you are a BRCA carrier or you're in that high risk bucket, where your risk is 5% or higher at 5 years, mammography alone won't do it. And ultrasound is not the right alternative. A contrast-based imaging study like MRI is the right thing. But the other thing that's kind of interesting about that is MRI, as you just heard, also gives you another piece of information. The background enhancement, or what we call BPE, is also a risk factor. So that BPE, if you can make that go away, that's probably an indicator that our treatments are successful. That's, to me, I'm pursuing this idea that this could be the cholesterol or the blood pressure equivalent in heart disease, right? You need an intermediate endpoint. And, I think I've been working on a prevention clinic for 20 years. One of the things that I think frustrates women, they're willing to take something, but they want to know that it's working or not. And we've been just terrible about that. We just don't have a way to do it. But I think looking at, whether there's a change in density or whether there's a change in the background enhancement could be that very thing. And it's actually very handy, because if that's the right way to screen someone who's at high risk, and you can see that going down, you could have a lot of confidence that what you're using is working. And this can be, again, the platform, just like what we did with iSpy. It can be the platform to start to usher in new approaches to prevention. And some of those approaches don't have to be medications. They could be change in diet, changing the microbiome, changing other things, but you have to have an early endpoint if you don't want the knowledge turns to be 20 years. You can't be, so I'm going to do a prevention study and it's going to cost $100 million and it's take 20 years. People just aren't going to fund that, right? But you could say, hey, I've got an early endpoint and I can test things to see if they work, and I can do it in a much more efficient way and a shorter endpoint. So these are the things, looking, that Carol Fabian did that with fine needle aspirates and looking for atypia. There's lots of things that we can do in that regard to push things forward faster. And that's what I intend. Our group intends to do that. So that's actually our Wisdom 2.0 will include all these kinds of prevention studies. So we're working on a program project with our whole big group of us.
Excellent.
To make that happen.
Yeah, that leads me to another question I had about risk factors. Of course, so much attention has been given in the media and in popular culture to the genetic mutations, such as BRCA, that could predispose a woman to an increased risk of developing breast cancer. Are we doing a good enough job informing our patients as to other risk reduction possibilities that they could introduce into their own life? You mentioned, diet and exercise. Is there enough evidence to show, good data to show that diet modification, healthy diets, and increasing physical activity, are those worth talking about with a patient, from a perspective of risk reduction?
Absolutely.
For breast cancers?
Absolutely. And it's already integrated into the Wisdom study. Why do you do risk assessment? To help figure out whether what the optimal screening regimen should be, but also to identify those people at highest risk and start talking about all the things they can do. There's no question. I mean, it turns out that, exercising every day or 5 days a week, for at least a half an hour, or, and then eating a more plant-based diet, that this is good for your overall health. And it also reduces your risk of breast cancer and other cancers. No question about it. No question about it. And we know people may not like it, but we know that drinking less alcohol is important as well. That's one of the few things that every single study looking at high rates of alcohol consumption increase your risk of breast cancer, as well as other kinds of cancer, head and neck cancer and liver cancer and colon cancer. I mean, but it's very, very clear. So I tell people you don't have to be a teetotaler, but try and stick to 3 to 5, the equivalent of 3 to 5 glasses of wine a week. And if you like to have more than one glass of wine, when you drink, then pick 2 nights at the most to drink. And the rest, get a fun glass with sparkling water and some pomegranate juice and an umbrella. Feel good about it. But, these are things that absolutely we can do to reduce our risk.
Right. Like so many things in life, it's finding a balance or a moderate, incorporating moderation. Finding a balance.
That's right. And there's no perfect answer. I mean, you can do everything right and still get breast cancer. So it's not, and you can do everything wrong and never get breast cancer. So there's never a perfect thing. But it's just like, if you get in your car, and you're a very safe driver, you can't stop the random guy who jumps the median strip and crashes into you headlong. But if you're a safe driver, your chances of not having and you wear your seatbelt is going to reduce your chance of having dying in a car crash.
Right. But on the subject of diet, so to bring up a semi-controversial topic, sugar consumption. We've heard a lot of back and forth, about, is there any association between increased sugar consumption and development of breast cancer? And it seems like the evidence has been kind of, not very specific. We know that sugar consumption is highly associated with development of metabolic syndrome and type 2 diabetes, which increase your risk of developing breast cancer. So, but the connection doesn't ever seem to be made between, increased sugar consumption in your diet could predispose you to a higher risk of developing breast cancer. I know, in your wisdom study, I assume that would that be incorporated? Would that be studied?
Well, this study isn't designed specifically to look at sugar consumption, but it doesn't, you don't have to be a genius to know that, trying to reduce excess consumption of sugar is a good thing. Eating sugar, this is one of the things too, but people would say, oh, I want to take a vitamin or a mineral and I want to do it in a pill. Well, that's not going to work, right? We have done that. We have run many studies to try and reduce the vitamins and minerals or whatever into a pill, and they don't work. Yet people who eat those kinds of diets have less risk. Eating healthy foods that are seasonal, is good for the environment, it's good for your body, it's good for your health in every single way, including breast cancer. Not eating excess amounts of sugar keeps you from getting diabetes, keeping your weight in, keep trying to keep your body mass index, to below 27. Those kinds of things are, it's just all common sense. And for sure, all these things are associated. I'm a firm believer that there are going to be things that we learn about the microbiome, which is, these colonies of bacteria that populate your gut and populate your skin, that there's going to be a link there as well that will help promote, healthful, or reduce your risk of breast cancer. We haven't quite figured it out. And the diet studies are challenging. It's hard to find that link. And it might be because there's an intermediary, and that is the gut microbiome. But there's a bunch of people studying that. I think stay tuned. I think that's going to be an exciting area as well. We're in the I-SPY trial. We're going to start to look at that. There have been even some studies suggesting that, the microbiome can influence whether you are responsive to immuno-oncology drugs. So there could even be dietary interventions along with some of the treatments. I think people are trying to think out of the box to come up with better ideas. But in the meantime, I think it's everybody should realize, getting their kids active and eating healthy diets from the beginning protects them long-term from all kinds of diseases, including breast cancer. Exercising every day, trying to eat a more plant-based diet, try to reduce the amount of sugar that's in your diet. Don't drink too much alcohol. These are just common sense things that everybody can do to protect themselves. And by the way, it will improve your health overall, which will make your life better.
Right, exactly. Yeah, I was going to ask you about the role of immunotherapy and just immune modification technologies in general with regard to breast cancers, including DCIS. I mean, I know initially a lot of the research early on kind of hit brick walls and roadblocks because so many breast cancers just didn't seem to respond all that well to some of the early stage, early developed immunotherapy drugs. But just as a layperson, it seems to me like the best anti-cancer drug that any human being has is our own immune system. I mean, why do some people get cancer in general and other people don't, or some people develop cancer and then their own immune system squelches it or destroys it? What is there to be garnered from that, to be learned about that process? That's why immunotherapy just a fascinating topic to me. It just seems like that may be the future of at least one potential future of breast cancer therapeutics.
So again, it's important, if we lump all breast cancers together, we'll learn nothing. Herceptin, which was, the miracle for HER2 positive disease, and now the HER2 directed antibody toxin therapies are probably going to be, I bet in 5 years, that'll be the first line treatment for people. We won't even have to use standard chemotherapy. I hope that's what we're going to try and show in I-SPY. But, if we had tested that drug with all breast cancers, we never would have found it, because only 10% or 10 to 15% of breast cancers are HER2 positive. So that's the same thing. There are certain kinds of cancers, the triple negative cancers or the hormone positive breast cancer that are more basal-like. It's a minority of the cancers that will respond to immunotherapy because it's a different type of cancer, and a cancer that certain mechanisms have been put in play to evade the immune system, and that PD-1 or PD-L1 inhibitors can unlock that and turn the immune system back on. Now, sometimes that comes at a cost and people get side effects from that. But I'll tell you, we are actually in DCIS, we are actually working on immunotherapy. What we're trying to do is we've created vaccination in what we call an in situ vaccination for in situ cancers, because you wouldn't want to try the immunotherapies which have toxicity. You can knock out your thyroid, it can knock out your adrenal glands. I mean, these can be, serious lifelong conditions that you have to deal with. Now, obviously, better to deal with that than dying of breast cancer. But if you have in situ disease, remember, your life is not on the line. So you don't want to do things that will put your life on the line. Everything's got to be a balance. So what we're doing is we're directly injecting those immunotherapies into the tumor itself, especially when you have these palpable masses that we know are higher risk. Now, the interesting things is, for most of them, if you have T cells there to begin with, you can really generate an immune reaction. What we now have decided, we're trying to do a combination with something else to see whether we can really turn on that immune response enough to have the tumor destroy itself with just a local injection. Early days in this research, study is open. We're excited about it. But we do know one of the things we've learned is if you don't have T cells there to begin with, it's hard to generate them, to make them come in to do that. So I think that also tells us that you have to really do a good job of understanding what tumor you're at risk for. And the DCIS type that you have is probably a pretty good indicator of that. And that's really what should target our ideas. If you're on this path, that these are the kinds of treatments or things that you should do to reduce your risk. If you've got the type B, you're going to take a different set of treatments that you're going to use. And that's I think the more personalized we get, the better we tailor our treatment to the biology that someone presents with and the background risk they have, the better we are going to be at really getting a handle on this and preventing people from getting a bad cancer or dying of it.
Definitely makes sense. That definitely sounds like a better approach than the current broad-based one size fits all approach that many
is not.
Could you touch on what are your thoughts on in terms of the therapeutics in the pipeline right now? The potential future treatment options. Such as the Artemis projects. The breast cancer vaccine work that's being done. What would you see as being the most and I know the wisdom study obviously is going to help you elucidate some of the what may be the best approaches here, but just a general discussion of what you think the future of DCIS care may be. Where will we be in 3 to 5 years if you had a looking glass to determine that?
Well, we're going to run a confirmatory study, but I would hope in 5 years that only about 30% of women wind up having to have surgery for DCIS. That's what I hope. In terms of the therapeutics that are coming down the line, I think I look to the work we're doing in I-SPY, which is if you have a cancer that's consequential, that is going to put you at risk for dying, that you start with the therapies up front. And we've moved from learning within the trial how to best assign the next person who's coming up to now we're switching to how to optimize the treatment for each person in the trial. So we've got block A. So it's like thinking about first line, second line, and third line. So with first line, we're going to start looking to these antibody drug conjugates. And some of these are, viral oncolytics, oncolytic viruses, or various approaches that don't use the standard chemotherapy. There are a lot of exciting new combinations out there that aren't standard chemotherapy, but they shouldn't be given as third line. Why not start up front? If you happen to have a good response, great, stop, move on to the next therapy. You can figure that out in 6 weeks. And then you get the best therapy for your subtype that we know of today. And that's some kind of taxane-based something, if maybe with PD-1 inhibitor, maybe not, depending on what you have. And then if you still have disease left, that's when you would use AC, or maybe even try something better. I mean, that's a drug that we've been using for, 70 years. I'm sure we can do better than that, 50 years. So I think that there are other things that we can do and other ways in which we can start to assess that and figure it out. And, there's so many exciting new therapies. They need to have their day in court. But as we start to understand the biology of each of these cancers and what they respond to, it will give us ideas for how to prevent them. People can have big cancers and have them be hormone positive and what we would call molecularly low risk. We know they're not going to likely respond to chemotherapy. So that gives us the option to start looking at the endocrine therapies combined with CDK4/6 inhibitors or aromatase inhibitor or various other, BCL2 inhibitors or various things that when we start to understand that, if we see someone with a precancer, especially if we've got a combination that's not too toxic, you can try that for 3 months. If it works, you're good. And how long do you need to treat? I don't know. But by having some of these markers up front, maybe we'll start to figure out ways to not make it so that the therapies are 5 years for people in these hormone positive cancers.
One final question. What would your advice be to a patient who has received a diagnosis of DCIS and been given a standard course of options, for instance, a surgery followed by radiation therapy? What would you tell that patient if they wanted information about alternative options? What would your best recommendation be to give to that patient? I mean, of course, get a second opinion, but would you recommend they look into clinical trials for some of these therapies?
So there's a bunch of clinical trials. There's the COMET trial that Shelley Wong is running. That's up in many sites around the country. We are actually going to be starting a trial this spring called the DCIS Recast Study. That is reevaluating conditions for active surveillance suitability as treatment, where hopefully that'll sort of pick up when the COMET trial stops occurring. And that will be at many sites around the country as well. And that will be this idea of if you have hormone positive DCIS, that you can try a window of therapy and we can look for the response on MR to determine, are you a good candidate for active surveillance or not? And at that point, after 6 months, then you can make a decision about whether you want to continue or whether you want to have surgery. But sometimes just, if you get rid of the background enhancement, you can actually see better where the area is that needs to be removed. Or maybe everything goes away, so you don't need to do it at all, which is what I think happens in 50-60% of people. But, we have to run it as a trial to figure that out. People are afraid of clinical trials, but quite honestly, clinical trials are tomorrow's treatments today. every new treatment that's available came because of a clinical study. Clinical studies are opportunities. And, not every trial is going to be something that you like or is suitable for you, but ask about them, understand about them. Many, California has a law that says if there's a clinical trial that's available, whoever your insurer is or wherever you are has to pay for you to go to the site that has that trial open, and your standard of care costs have to be paid for at that site. Jackie Spear helped write that legislation. I worked on it with her 20 years ago when she was a state senator. And there are 36 states that have such legislation. We're actually working on trying to make that national legislation as well. And it's just so important that people have access to trials. Not every site can open a trial. I mean, some sites are suited to that and some are not. But every person in the country should have the opportunity to go to participate in a trial. And there are some foundations like the Lazarus Foundation that will help support travel or the expenses of participating in a trial. We have to create the ecosystem that makes access equal for everybody. It's so important.
Absolutely. So, speaking of access, where would you recommend a patient go to obtain information on available clinical trials? Is there a centralized website that they can go to?
There is actually. There's something called breastcancertrials.org. Our organization started this about 20 years ago, and it's actually quite sophisticated. You can actually, if you go to bct.org or breastcancertrials.org, we have over 750 trials cataloged from DCIS to stage 1, stage 2, 3, and stage 4 trials. So you can look on those on that to see. And it's patient facing, and you can put your own information in. And we're lucky because breast cancer is really quite well organized.
Excellent. Yeah, that's an excellent resource for patients to have, in terms of determining their approach, to their newly diagnosed disease. Dr. Esserman, you have been so generous with your time today. I appreciate all the incredible, valuable information you provided us, and definitely wish you the best on the wisdom study and all of your research in general. You are a force for change, getting us closer and closer to a cure. So we appreciate
Well, I hope so. I'm impatient for my patients.
There you go. Excellent. Well, thanks again, Dr. Esserman. We really appreciate it.
So welcome. Pleasure to be here.
Thank you.